Hello everyone, my name is Dr. Omar Sabri. I'm a consultant orthopedic surgeon and head of department at Saudi German Hospital. Today I've got one of my colleagues, Dr. Peter Birch. I'll let him introduce himself.
Hi, I'm Peter Birch. I'm a consultant orthopedic surgeon from the UK, based now at Saudi German Hospital. My special interest is in knee arthritis and the management of that, with a further interest in arthroplasty and revision knee surgery.
Thank you, Peter. Obviously, this month is Arthritis Month, and we thought it'd be a good opportunity to have a chat about what is arthritis and discuss the various treatment options that we can offer for patients suffering with this terrible condition. We know it's obviously very prevalent throughout the whole world, and let's start by describing what is arthritis. Arthritis, essentially, it means loss of cartilage from the articulating surface or the joint surface. A cartilage, as we know, is the smooth gliding surface of any joint, and it's present on the ends of long bones. So let's take the hip, for example, which is a ball and socket joint. And what happens is you get loss of cartilage from the ball and the socket, the joint space wears out, and you start to get all the symptoms of arthritis. In the hip, it's traditionally pain, which reduces your ability to function. You get limitation of movement. Some people with hip arthritis struggle to reach their toes to either put shoes and socks on or to cut their toenails. They struggle to get in and out of cars, and they're generally quite limited. Their walking distances start to curtail, and they start using more and more painkillers, and it starts affecting their quality of life. Generally, there are various treatment options offered for arthritis for this condition, depending on the severity of the condition, and there are grades. And we tend to, when we see someone, we tend to identify the grade and then offer various treatments based on how much the patient is suffering. We also arrange for some X-rays and MRI scans to be able to better identify what level the patient is at, and then tailor-make the treatment specifically for them. Peter, I know the knee is obviously a bit different. Do you want to tell us a bit more about knee arthritis?
Yes, so the knee is similar in that it has cartilage covering the ends of the bones, but we also have the kneecap in the knee, which has the thickest layer of cartilage in the body, but has its own particular problems. And then also in the knee we have ligaments, which can be injured, and then we have the meniscal cartilages. And it often gets a little bit confusing when we mention cartilage and cartilage. So we will, from this moment on, we'll call it the meniscal cartilage or the meniscus, and the ends of the bone, when we talk about cartilage, we'll be dealing with the articular cartilage. So in the knee, clearly the knee has a lot of injuries through sports and other activities, and ligaments can get damaged. And one of the early signs of the beginnings of degeneration of a knee might well be some pain at the joint line, or some sounds climbing up and down stairs, or pain going down hills, etc. So the knee is slightly different. We have more structures which can be injured, and therefore the treatment options for knee arthritis are again different from hip arthritis.
Okay. So we mentioned the treatment algorithm, and obviously we know that we try and tailor-make the treatment specifically for patients, not just depending on the grade of the arthritis, but also depending on what their level of activity is and how old they are. So can you tell us a bit more? Let's start with non-operative treatment.
So I think with non-operative treatment, we should always start off with simple things. So we're looking at lifestyle changes. In the knee in particular, body weight does have a huge effect on symptoms. So a healthy lifestyle, reducing body weight, the use of simple analgesics is always a good starting point. But then really, motion is a lotion, so movement is life in all joints, and particularly the knee and the hip. So exercises, and together with that, physiotherapy. I think physiotherapists have a huge role to play in teaching us how to look after our joints, and then we take that forward in the future. With knee arthritis, the exercises are really for life, but you need the physiotherapist to teach you how to do them properly. And they also have other things which can be helpful in the acute stages, such as hydrotherapy. I think you were talking about hyperbaric oxygen as one of the therapies that can be used, if you'd like to expand on that role.
Yes, hyperbaric oxygen is essentially having the patient inside a high concentration oxygen chamber. And the idea is that it reduces the antioxidants present in the body and also it increases not just the blood flow, the quality of the oxygen delivery to all the tissues. So if you have an organ that's struggling a bit with any kind of disease, by increasing the amount of oxygen that's reaching that organ, you're promoting healing and turnover of new material, new substances within the body to promote the healing of that organ. Cartilage is the same. We know cartilage doesn't particularly have a good blood supply. In fact, it's probably one of the worst organs for nutrition with blood. It gets its nutrition from the synovial fluid mainly. But increasing the oxygen concentration of the whole body or of a joint will have a beneficial effect for sure. You mentioned the role of the physiotherapist, and I think that's very crucial and really important. I think patient education is really important, and we see that especially in this part of the world, in Dubai, where we live at the moment. We have a very high concentration of what I call the recreational athlete. They're essentially you and me. They're deconditioned athletes who basically spend all their time at their jobs, most of the time sitting at desks or sitting in a car for long hours. And then they have limited time during the day where they want to maximize the effect of exercise. And unfortunately, they push themselves too much towards high impact loading exercise. And that can have a detrimental effect on the knee and other joints. You want to expand a bit on that?
Yes, so in my practice, I see paddle tennis has become very popular, and I think people forget how demanding that is on joints. And it's the muscles around the joints which spread the load from the joint and protect the joint. And with poor muscles, huge amounts of force are put through the joints and the ligaments. And we see a huge number of cruciate ligament injuries, meniscal cartilage tears, which, if they're not treated appropriately, will lead on to further degeneration and wear and tear of the joints.
I think that's absolutely right. And I think going back to the deconditioned athlete, the idea is that we do regular exercise, non-impact loading exercise, to keep your muscles fit and healthy and to condition yourself before you get into the high impact loading exercise, which is part of the problem. Okay, so moving on a bit from what we call conservative or non-surgical methods of treating arthritis, what's the next step?
So sometimes it's the first step. So if someone has an obvious articular cartilage injury, then arthroscopic or keyhole surgery does have a part to play in the management of arthritis in the knee. We can repair chondral injuries, cartilage injuries. We can replace areas of cartilage damage, and also we have the ligament and the meniscal reconstructions. So that would be the first area of treatment in the management of knee problems. We could then look towards doing some form of osteotomy. So if you have a mechanical alignment problem in the knee, then cutting the bones to realign the knees to spread the force is one of the next steps that we can consider. And then we return to arthroplasty. So that is the end stage for most arthritic joints. In the knee, we have the option of doing partial knee replacements. So if only part of the knee is damaged, we can consider either replacing one or two parts of that joint. If we have more problems with the knee or other tightnesses or other issues which can't be corrected by a partial knee, then of course we move to total joint replacement. And in the hip, how do we manage that? I don't think we have partial hip replacements.
Well, we do, funny enough, but that's only for a fracture of the ball, essentially, of the head of the femur, should it happen in the elderly. So that partial replacement is actually reserved just for this group. If you have a younger, more functioning patient, either with a fracture or with arthritis, then the accepted treatment is a total hip arthroplasty or total hip replacement, in which we replace both parts of the joint, so the ball and the socket. And there's various ways of doing that now, and now the technology is actually available to do this robotic-assisted. The advantage of robotic-assisted surgery is that it gives us more precision on where we place the implants. So whereas previously we would use anatomical landmarks, which was reasonably reliable, but now we can, we're talking sub-millimeter accuracy and sub-degree accuracy here, and being able to position the implants exactly where we want them. What are the advantages? Well, it's a quicker recovery for starters. And then we haven't got the data yet, but the suggestion is that this will improve the longevity of these implants. They'll survive longer because they've been put in more accurately. So that's with regards to hip replacement. It's just mainly two main components that are fixed within the bone. One is in the thigh bone and one is in the pelvis. And then you have the articulating surfaces, which for most of the replacements that I do, I choose a ceramic on polyethylene bearing, which is the combination that's surviving the longest on the UK National Joint Registry. I know the knee is a bit more complex, and it involves, as you mentioned, pretty much 3 joints. So what are the latest options in knee replacement surgery?
Yes, I think you've hinted about the registry, and it's the registries which have been a game changer in joint replacement, in that we have so much data now going back 20, 30 years to show us which combinations are the best, which implants provide us with the best outcomes. And so you may find that the best implant is actually one that's been around for a long time. So in my practice, the biggest change in the last 20 years is the plastic bearing in between the two metals. So in knee replacement, we have a metal bearing on the end of the thigh bone, and then we have usually a metal plate that's in the shin bone, and in between that we have a plastic articulating spacer. And in the last 10 years, certainly, the dramatic changes in the quality of that spacer means that we can expect very little wear in the future. The kneecap has always been a conundrum. My practice is to replace it routinely, but that is still open for debate.
Interesting. So my practice is not to replace it routinely. I'm a selective kneecap replacer, depending on the amount of wear that I see or the patient. And even in the knees now, we are also doing robotic-assisted surgery, again, to try and add that element of precision to hopefully get the implants to survive longer and longer. And as you mentioned, the improvement in the biomaterials that we've had available in the last few years has been a great leap forward in terms of what we can expect to achieve with joint replacements going forward. I think this is just a quick overview of arthritis, especially affecting the hip and the knee. We are both consultant surgeon at Saudi German Hospital. We are there to look after you and look after all your needs. If you're suffering with arthritis, come down and see us, and hopefully you'll be able to tailor-made a treatment specifically for you.
Saudi German Hospital, caring like family.